Mr. Thompson.
Well, first of all, I want to thank the chairwoman and ranking member for this hearing. This is extremely important. I came to Congress after 28 years as a healthcare manager, and I appreciate the words my colleague just shared in terms of the issue with medical liability, the cost of that out of pocket for physicians, but the cost to the system with, frankly, having a medical record to be able to defend yourself with, that plaintiff attorney that's not seen but always present. And the workforce issue, which is significant. And I appreciate the panel being here. It sounded a little bit like a family feud here, the past couple questions, and there's a lot of competition for future professionals, future providers. I'll start with Dr. Harbaugh, and then we'll see if any others have a good handle on. Frankly, instead of competing for the, I know right now it sounds like you're competing for these folks. What's the estimated shortfall over the next 10 years of the actual need of practitioners versus the supply, given the current trends in enrollment that are out there?
Well, the numbers that I've heard is that if you look by 2025, there's an estimated 46,000 person deficit in primary care and about a 41,000 deficit in surgical specialties. And I think nobody here is questioning the need to support primary care physicians. The concern from the surgical specialties is that if that is done at the expense of the surgical specialties, which is what happens if you restrict residency training and give special relief of debt repayment, et cetera, if you say we're only interested in primary care is where all the focus has to be, then I think you really run the risk of fixing that problem, great, but exacerbating another problem. And I think the surgical specialists are as important as primary care for the overall health of the nation, particularly in areas like trauma, where it's not going to go away, and you need surgical specialists to be there right away in a life-threatening situation. That to exacerbate the one problem to fix the other doesn't make sense to me.
Well,
we had publications in Health Affairs about 2 years ago, and the numbers go between 20 and 40,000 of doctors across the board. Now these numbers aren't going to be right looking back, because the medical schools are a target of 13% increase, with now 130 medical schools as just the last few years. The problem, though, is at the residency level, because if we don't get something fixed there, changing the Balanced Budget Act, and that we're going to just be robbing countries that can't afford to give us their people. I've worked all my life in public hospitals, and that's what we're going to be doing. And we ought to be able to have our workforce funding be self-sufficient.
Well, that's a good segue to kind of part two of my question is, how do we fix this so we're not competing back and forth, that we're growing enough future professionals to meet all the need, because the need's significant with the aging baby boomer population, the attrition of retirements that has been happening for some time now. It's going to intensify, plus the amount of need that will be out there as the population ages.
If I can make one more comment. Dr. Griffith's comments are germane in that if number of medical schools and residency growth had continued beyond 1997 at the pace that it was before, we'd probably be okay right now. But we froze everything at that period of time with the Balanced Budget Act and with a voluntary cap done by the medical schools.
Yes. The graduate medical education, no one's mentioned about the fact that Medicare, right now the residents are reimbursed through the hospital in this convoluted formula of direct and indirect payments. And meanwhile, about the last 2 decades, Medicare funds have been going to independent insurance companies who don't contribute back to the graduate medical education system. It's only on the back of Medicare and Medicaid. And I think that would increase the GME slots tremendously, because at the medical school level, we're all doing our job trying to increase the class sizes by 15% on the allopathic side, and we've doubled our schools on the osteopathic side. But if you can't place your residents when they're done, and it's just, the students vote with their feet. They're not stupid. They see what's going on. They know business a little bit. They can figure it out, and they say, I don't want to do this because I can't make ends meet, but I can do this. But if the GME slots were more available, some of the ones that don't get filled, there would be others that would get filled. Right now, there's this understanding that the GME slots are dedicated to certain specialties. They're not. They belong to the hospital, and they can divvy them out any way they want. And if you don't use them in 3 years, you lose them.
Okay. Thank you, Madam Chairwoman.